Minister Ong Ye Kung.
Mr. Deputy Speaker, I rise in support of the motion. I want to thank Dr. Tanya Swam, Dr. Shahira, and Mr. Abdul Samad for tabling this motion and pointing out passionately that health is everyone's concern. And it's only with everyone's action that we can improve the health of individuals and of our nation. And I would also like to thank all MPs and representatives of ministries who have, through your speeches, supported the various health-related policies and also given suggestions for improvements. And this include Healthier SG, our preventive care strategy, championing the well-being of our healthcare workers, developing more centralized IT systems, group buying of drugs with private doctors, ensuring that healthcare remains affordable for everyone, etc. Members have also raised a range of challenges and frustrations of the healthcare system. And indeed, healthcare is probably one of, if not the most complex public service systems in our whole public service. It would be unrealistic of me if I were to say we have a solution to every problem that you have raised. Even if we have, theoretically, it's not practical to implement them all. We will need to work within the budget and time resources we have, our management bandwidth to plan and effect change, our people's appetite to accept changes, and we have to improve step by step. What we will do is to prioritize the areas that we can make the most meaningful changes where there is bang for the buck and focus on them. And this is what we are doing. So we are focusing on expanding our healthcare capacity, which includes manpower, rolling out Healthier SG, and building up an effective system for aging in the community. And together, I think they represent a major transformation of our healthcare system in the medium term. But before I talk about these priorities, let me first address three specific issues on healthcare that were raised by members: manpower, financing, and Professor Jason Slim just raised healthcare capacity. It's last minute, but I'll respond to you. First, manpower. At the heart of any healthcare system are the workers. Several MPs, such as Dr. Tanya Swam, Ms. Janet Ang, Dr. Wan Rizal, Mr. Gerald Giam, Mr. Abdul Samad, and Mr. Raj Joshua Thomas, have spoken about the issues confronting them. And we have to support healthcare workers as much as we can. The NTUC and the HSEU, they have been fervent supporters for the welfare of healthcare workers. Ms. Tanalechmi, President of HSEU, used to be an MP in this House and spoken about it many times. The partnership between the PAP government and the labour movement, this is a strong institutionalized arrangement, and MOH looks forward to our continued partnership in advancing the welfare of our healthcare workers. And part of this work, very importantly, is to regularly review remuneration of healthcare workers to ensure that we recognize their contribution and to make sure that remuneration is competitive. Mr. Leon Pereira suggested some benchmarking. We will internally benchmark, not just the pay, but also taxes, because it varies across countries, but also living conditions, rental. But I suggest we do this internally, because competition is now so tough. You don't want to benchmark and then show everybody. But we certainly want to benchmark and make sure we are competitive. Right now, in fact, rental becomes a problem for foreign nurses to come to Singapore. And our pocket expenses is high. These are some things that we need to address to make sure we are competitive. Of particular urgency now is to actively recruit both local and foreign healthcare workers to boost the workforce, given the rising attrition suffered in the last 2 years due to the COVID-19 pandemic. For local healthcare workers, we are looking forward to the inflow of the latest batch of polytechnic graduates who I think just graduated, and they will be joining the workforce and joining our hospitals soon. Mr. Abdul Samad had a feedback about interns not getting paid for their internships. I would like to clarify this. All ITE and polytechnic nursing students they are given allowances for their internship attachments. However, for certain healthcare-related courses, such as you are a biomed science student, allowances is an arrangement left between employers and the school to set. And practices can differ across healthcare institutions. But given your feedback, let us look into the specific instances where our public health institutions do not offer internship allowances. As for foreign healthcare workers, it takes time to conduct selection, examinations overseas, and for the shortlisted candidates to move here. They have so far been trickling into Singapore, but we hope in the second half of the year, more of them will start to come on board. And for those who have performed well and are committed to Singapore, we welcome them to apply for PR. A few MPs have suggested granting PR status to their dependents as well. And we thank the MPs for your suggestions. This is worth serious consideration. For everyone in our healthcare workforce, we will need to ensure their well-being. And I'm glad many MPs spoke up against abuse and harassment of healthcare workers. This is one of the top issues in the minds of our healthcare workers. And I think, in general, I would say, to be fair, the regard and appreciation for healthcare workers has generally gone up amongst our society post-COVID-19. A majority of the public, they are appreciative and respectful towards our healthcare workers. Those who physically assault, threaten, or hurl vulgar and condescending remarks against healthcare workers, I think is really a small minority. But because the acts are so egregious, it feels like a big thing. And it does feel like a big thing, and it is a big thing. And we cannot tolerate such behavior. This is unfair to healthcare workers, unfair to the great majority of the public who respect our healthcare workers. So, as members know, MOH has recently announced a zero-tolerance policy against abuse and harassment of healthcare workers. And we intend to translate this to procedures and guidelines for all our healthcare institutions in the second half of this year. I will not elaborate what it entails. I've spoken about this before. But since the announcement of the policy, I've noticed some reactions. The best is most members of the public, I think, support the policy. Second, a few raised concerns that there were occasions where healthcare workers did not behave appropriately. And we acknowledge that there are always a minority of black sheep, but there are appropriate channels to report such matters, and the hospital management will look into them seriously. Some have said one of the root causes of abuse is the heavy workload at the hospitals and long waiting times, and therefore we should address that first. We are doing what we can to alleviate the situation at the hospitals post-COVID-19. It will take time, but heavy workload cannot be an excuse for anyone to physically or verbally abuse our healthcare workers. Mr. Raj Thomas mentioned another reason is expectations are high, and when it's not met, people get upset. It's totally all right to have expectations and to demand good service, but by all means do that, but there's no need to abuse healthcare workers should expectations fall short, or should service delivery fall short of expectations. I should say that notwithstanding the heavy workload and the occasional abuse and harassment, most healthcare workers I met, and I hope it's not just because I'm minister, but most of them that I met, they remain positive and professional and passionate about their jobs. Ms. Ko Fang Chi, for example, she was a senior staff nurse in Khoo Teck Puat Hospital since 2015. She has now become a nurse manager. So over the years, she dealt with many abusive patients and next of kin, but she continued to calmly handle each one with empathy, became an expert in this field. Once, she witnessed a junior nurse being abused physically and verbally by the next of kin of a patient. So she bravely stood up, managed the situation, escalated the incident to the authorities for follow-up, and remained calm throughout the incident. And despite all these challenges, you can tell she loves her job. And she continues to treat patients and their loved ones with care and kindness. And she constantly shares her knowledge and experience dealing with abuse cases with her colleagues. The test of zero tolerance policy is in the second half of this year when it becomes guidelines, when we empower supervisors to disengage abusive patients or most likely their next of kin. What happened? I do expect some to write to the ministry, complain to me why do our supervisor and nurses act this way. We will be very careful. We will make sure that only the most genuine cases will effect the consequences only for the most genuine cases. And care will always be prioritized. So should I get a complaint, I will back up our ground supervisors. I will back up our healthcare workers. Should it come to this chamber? Because I think some of the residents will complain to their MPs. Why did MOH act like that? Can you appeal against this? They disengaged me, and I was just demanding good service. What do you do? And I hope that when the time comes, when the test comes, I hope to have the support of this House. We will be careful, and we will do it judiciously if we ever have to disengage an abusive patient or next of kin. So I seek the support of the whole House. Now let me move to healthcare financing. Mr. Leong Man Wai made a few points yesterday. I'm glad he agreed with our policy to use Medifund to support low-income families. The Medifund disbursed $164 million in FY21, not $100 million as stated by you yesterday. Government further topped up Medifund by $1.5 billion in FY23. However, Mr. Leong also delivered a political statement yesterday. He declared the PSP's position the government ought to spend more in healthcare like other OECD countries. Let me make a few points in response. First, it is widely known that spending more on healthcare does not mean better health outcomes. Most health economists will know that. Since Ms. Leong is benchmarking ourselves against OECD countries, let us just cite two examples, US and UK. They are spending about 17% and 10% of their GDPs on healthcare, compared to us, 4%. Yet US and UK continue to face high incidence of chronic illnesses, high obesity rates, and their expected lifespans are lower in Singapore. I also check out ChatGPT. What do you think of US system? What do you think of UK system? Inspired by Mr. Eric Chua. Actually, it's quite well known. In the US, healthcare is very expensive, despite spending 17% of their GDP. In the UK, NHS is crushed now by the workload. The waiting times are far longer than in Singapore, despite spending 11 or 12%, 10% of their GDP on healthcare. We have delivered good health outcomes given what we are spending. Second point, for whatever we are spending, we are able to make healthcare affordable for middle to lower income groups. So today, about 7 in 10 Singaporeans in subsidized wards do not have to pay any out-of-pocket expenses. I mean, 7 out of 10. 8 in 10 pay less than $100 cash out of pocket. 9 in 10 pay less than $500 in cash out of pocket. So when Mr. Leong asks government to spend more to lower out-of-pocket expenses further, he really meant to channel resources to unsubsidized patients. That is, those staying in A-class wards or private hospitals. This is where the big bucks and big expenditure are, and it will push our healthcare expenditure and spending to the levels of OECD countries. Third, while Mr. Leong asked government to spend on healthcare, he failed to mention that government expenditure ultimately has to be raised from the people through taxes. Mr. Leong had not made any mention of where PSP will get the funding from. Fourth, and the fact is that we are already spending more and more on healthcare. We don't need Mr. Leong's urging. Healthcare spending is going up. In the decade after 2010, our nominal government health expenditure tripled. In the following decade, that means up to 2030, it is expected to triple again. So triple and triple, increased by 9 times over 20 years. This is driven by an aging population who is also getting sicker. MOH already has the second largest ministry budget after MINDEF. In the coming years, our challenge is not to spend more, but to ensure we do not go the way of many OECD countries with a healthcare fiscal burden spiraling and escalating out of control. Finally, it is therefore much better that we continue our sensible and practical approach at different layers of safety nets, subsidies, MediShield Life, which I thank Professor Hoon Hien Teck for explaining why it's necessary, MediSave, MediFund, S+3M approach, which has worked quite well. We now combine this with a very important strategy in Healthier SG and our effort to enable aging in communities so that we can avoid sickness and reduce our disease burden even as our population ages. Mr. Leong also talked about the seemingly large balances in the Pioneer Generation and Merdeka Generation funds, the PG and MG funds, and concluded that more subsidies can therefore be given to PG and MG members. His understanding is misplaced. Both funds were sized based on the projected lifetime cost of the benefits and accounting for inflation and interest accrued. So, to illustrate, the oldest and youngest Merdeka Generation member is 73 and 64 years old. PG members will be at least 10 years older, with the youngest at 74 years old now. They still have quite a bit of runway ahead of them. And we do expect many of them to live until 90 or 100 years old. So their lifetime benefits need to be funded from the two MG and PG funds. But the government will continue to regularly review the adequacies of these two funds. Third issue is healthcare capacity that Professor James Lim just raised. We agree that 80–85% occupancy rate is probably ideal. We agree. We always felt, and you don't need an engineer to conclude that actually you must have redundancy in your system. It's not a new concept. It's something that I think we all agree to. But why is there a crunch now? First, of course, there will be a crunch during COVID-19. It's an emergency. It's a crisis of a generation. I don't think any country, any system can plan for that kind of capacity to cater to a crisis. But I think post-crisis, we do have a crunch today. I explained in this House before, I think it was during the white paper debate on COVID-19, that the main reason for the crunch is that within a very short span of 2 years, suddenly you see average length of stay gone up significantly. It used to be 6 days. Now it's 7.1 days. That's more than a 15% increase, which means suddenly your utilization gone up by 15%. Over 2 years, post-COVID. It's a post-COVID phenomenon. I think in time, researchers, clinicians will study why. But there could be a few hypotheses. One is, of course, some kind of immunity debt. More old folks are getting infected with viruses, bacteria, post-COVID-19, and when they do, they fall quite sick, and they actually stay in hospital for quite long. And that pushes up average length of stay. And another reason, which is a possible one, which is that during COVID, too many of our seniors decided to hide at home, not afraid to come out. There were no more community activities, which actually is so crucial to keep them healthy. So with social isolation, their health deteriorated, then they get infected, they stay in the hospital for very long. So that factor alone, 15% increase in utilization, explain why we have a crunch now. And it's happening not just in Singapore, it's happening all over the world. Every country is facing a crunch in their beds. All of us agree we must have redundancy, but all of us are facing a crunch, including especially OECD countries, despite their higher bed-to-population ratio. So what do we need to do? First, catch up on the capacity. Many of our projects have been delayed due to COVID. We have to catch up. But some things can't be rushed. We just have to implement them. So sometime this year, the integrated care hub at Novena will open. It will add a couple hundred beds. Woodlands Integrated Health Campus, by end of the year, Maybe one ward will open. Hopefully next year, more wards will open. And then we have the redevelopment of Alexandra Hospital, the Eastern Regional Hospital, Professor James Lim talked about. We have a redevelopment of SGH campus that's ongoing. Although it's a redevelopment, although it's an existing campus, it's a significant redevelopment with many more beds added. So that's one. Number two is build more TCFs, which I explained before. It's actually very useful. Today in our hospitals, there's still quite a number of, especially seniors, who are staying there not because of medical reason, but because of social reasons. TCF is rehabilitative care. It has good medical facilities, and it can allow those who are stable to move to TCFs, thus freeing up acute beds. So we are building that up quite actively. And third is recruitment, which I've explained before. And so I think, although it's very competitive, Singapore continues to be an attractive location for foreign nurses to want to come to Singapore. And the healthcare profession continues to be quite attractive to our locals as well. Today, 1 in 25 students will join nursing, and I cannot hope for more. 1 in 25. So you go to any class, 25 pupils, 1 will be a nurse. That's not bad at all, considering the number of options they have. So I think we are getting our fair share of local talent. I think we are competitive in hiring foreign nurses as well. But of course, I hope the House, having raised all this issue, you will support the necessary steps that we need to take in order to recruit local as well as foreign nurses. Now, let me come back to the substance of the motion, which is really why we are here. And it is an important motion, urging a whole-of-government approach to support healthcare even after COVID-19 crisis has passed. Our public service has a long history of interagency collaboration. But COVID-19, I think, was special. It was a period when we witnessed the tremendous potential of interagency cooperation, united in a common objective to overcome a national crisis. So you look at our schools, they kept education going, shifted to home-based learning only for a couple of months. Our economic and social agencies work together, support businesses, support workers. Various agencies got together, set up quarantine facilities, testing, community care facilities. And I cannot emphasize enough how much that meant to the hospital system, which would have otherwise bear the full brunt of the pandemic, and we would have likely collapsed. Recently, a well-known Chinese infectious disease expert, Dr. Zhang Wenhong, after he observed how life in China has gone back to normal during the May Golden Week, he wrote a blog and he said, I quote, "It was as if nothing had happened, yet everything has happened." In Chinese, 一切都没发生，一切都已发生. It was a rather poignant expression of the post-crisis state of mind, I think which may be relevant in Singapore and relevant to today's debate. We don't want to hang on and relive the crisis. We need to walk out of the shadows, put it behind us, look into the future. And yet so much has happened. The experience and lessons learned will reshape the way we look at healthcare, reshape the way we look at interagency collaboration. And those cannot be forgotten, and those cannot go to waste. So I share members' hope that while the crisis may be over and peacetime workload resume, it cannot be business as usual. We should usher in a new era of even tighter interagency collaboration. And this is especially relevant to healthcare for 2 reasons. Number one, as I've explained, aging is probably the biggest social transformation for Singapore in the next 10 years as we become a super-aged society. And this will have implications across multiple policy areas in employment, in our competitiveness, retirement adequacy, urban planning, education, and of course, healthcare. And it will draw ministries together to work in concert. Second, post-COVID crisis, we have decided that the conditions and timing are right for us to effect a major healthcare transformation, building upon all the work that was done in previous years. I've explained in this House why and what we are doing in this transformation. Essentially, the idea is that healthcare needs to go beyond treating sickness in hospitals and clinics, but creating health in homes and communities. In other words, health is not just relevant to patients who have fallen sick. Health is for all. And that is why we regard the healthcare system now as three interlinked systems. If I briefly recapitulate, Ms. Janet Ang has just explained this earlier. First, we have the acute care system, which is essential in ensuring that those who are sick get treatment. Second, the population health system, which we are building up through Healthier SG. And we are mobilizing all our family doctors and GPs to focus on preventative care that is anchored in the community. And the third is the aged care system. The default for aged care cannot be nursing homes or seniors living alone with no social support. In other countries, loneliness and social isolation of seniors have become an epidemic. We also see this happening in Singapore. It's one of the reasons why length of stay have gone up, I think, and especially after COVID-19. And if we can do this right, I think we can do what Mr. Yip Hong Wing suggested, integrate care across medical and social realms. And we need to urgently step up this whole of society efforts to enable our seniors to live their golden years in dignity, age actively in their community with their friends and family, involve them in activities, including training programs, like what Mr. Mark Che has suggested. And if they wish, live well in a family environment surrounded by their loved ones. So this aged care in community is the next major area of work in healthcare. To make health for all possible, we need the contribution of every stakeholder, public or private. When healthcare is mostly about treating sickness, it falls under the domains of hospitals. But when healthcare is about creating health and caring for people in their homes and communities, it becomes everyone's business. Hence, in order to realize health for all, we also need all for health. And I think this is really the spirit behind the motion put forward by the members. In particular, the following stakeholders can make significant contributions to health. First, employers. I thank Dr. Tanya Swam for speaking on this. Many of us spend a considerable amount of our adult lives at work, and hence the workplace is highly influential in shaping our health habits. I value our existing partnerships with NTUC, SNAF, and the Tripartite Oversight Committee on Workplace Health and Safety, or Safety and Health, who have been working with companies to promote good workplace health practices. With Healthier SG, employers can work closely with your panel doctors to join Healthier SG and to continue providing regular and proper screenings for employees, provide healthier canteen food, provide physical activity programs, mental well-being programs, and better work-life balance. We also urge employers to play their part in making sure those eligible are all part of Healthier SG. By promoting good health, employers will have more productive and happier employees, which is good for businesses. Second are our community partners. SBS Eric Chua has shared about MCCY's effort to mobilize the community to foster social cohesion, promote health, and develop a strong partnership with family doctors. Dr. Tanya Swam also suggested the need to have activities that cater to different segments of population and their varied interests. And indeed, when we consulted the public during Healthier SG, we heard from many residents that peer and family influence is a key factor in motivating them to adopt healthier life habits, such as regular exercise and to eat healthily. So under Healthier SG, our healthcare clusters will work with community partners, HPB, PA, Sports SG, to proliferate physical activities in the community and encourage strong participation by residents. And we welcome other ground-up initiatives and activities that rally the community. If we take a walk in public parks today, we spot many of these activities, many of them not organized by any agencies. Friends getting together to cycle, to run, to play football. masters teaching their disciples Qi Gong or Tai Chi, all of them are now part of the healthcare system. Third area, schools and education institutions. I thank MOS Gan Xiao Huang on speaking about MOE's efforts in building this health foundation for our young. Indeed, good health starts from our values, habits, and choices. Our schools help to build this foundation of health literacy. They introduce our young to sports, help them make friends and form social groups, teach them life skills and knowledge to be useful citizens, all of which are essential building blocks for good health. And as mentioned by MOS Gan Xiao Huang earlier, through the years, MOE has worked with MOH to thoughtfully infuse health education in its curriculum, from early childhood to primary, secondary, and tertiary education. Research findings now show good health habits, such as proper diet and use of devices, inculcated from as young as 3 or 4 years old, have a profound impact on the cognitive development and well-being of the child later on in life. And it actually does affect their PSLE results, based on our research findings. Maybe that's the right button to push, I don't know. So MOH, MOE, MSF, we are studying the linkages between early education and health and developing possible interventions. Fourth, the media. Information and media literacy is our first line of defense against false and viral health myths. We will continue to work with MCI and other media agencies to do this, just as we did during COVID-19 to dispel falsehoods about vaccinations. Healthier SG gives us an opportunity to address the problem of health misinformation. How so? This is because we are advocating and trying to build up stronger patient-doctor relationship. Because with a trusted relationship and the family, doctor, and his care team knowing the health condition and health history of the patient, they become the patient's trusted source of medical information and advice. In this digital era of information overload, online falsehoods and myths, and AI bots, perhaps what we need in healthcare is stronger human relationships, especially between doctors and patients. We can use technology to strengthen the relationship and improve the quality of care rather than replace the human relationship. That must ultimately be the mode of coexistence between humans and AI. And finally, our infrastructure and transport planners. Over the years, MND and MOT colleagues have expanded green spaces, cycling paths, fitness corners island-wide to support active living. And there are also plans to have more silver zones and green man plazas at pedestrian crossings to allow seniors to travel more safely and with confidence in their neighborhood. These are many examples of how agencies are coming together to better support health, and we are committed to continue to do so. Mr. Deputy Speaker, let me conclude. I'm mindful that our NMPs are coming to the end of your term. This is perhaps your second last sitting. I don't know for sure, but leader told me it might be your second last sitting. I know some of you hope to have the assurance that even as you step down, the issues close to your heart continue to receive attention in this chamber. So I feel honored and privileged, although it got me a bit busy, that you have chosen to table a motion on healthcare, just as you have actively been speaking up on healthcare issues during your term. In particular, Dr. Tanya Swam, who was also the president of the Singapore Medical Association, she has been a strong advocate for various healthcare-related issues. I attended a SMA dinner some time ago, hosted by her. And in her speech during that event, it's public, yeah, so I think I can say it. In that speech, she said that she was an angry young doctor, and now you are a less angry middle-aged doctor. But what's the difference is that you now learn how to channel your energy to a greater good and be a better advocate. I say Dr. Tan is doing a good job, both in SMA as well as in this house. But I don't think Dr. Tan is angry. It is important that we are passionate in our cause and be active in our advocacy. I greatly appreciate this motion, highlighting the need for MOH to work with other agencies and for other agencies to support us. Today, we got MOE, MCCY, POHs to deliver their speeches. But actually, we could have gotten many more. But we don't want to prolong the debate for too long. Aging is going to be the big challenge that affects all of us, and MOH cannot be alone in this. The passion and activism of our NNPs help uplift the standard of debate in this House and bode well for the democratic discourse for Singapore. So please rest assured that the issues close to your hearts will continue to be given due attention in this House, even as your term comes to an end. There will be a new batch of NMPs who are passionate about issues too and take up the issues that you care about. On healthcare, there will be MPs who are healthcare professionals, GPC members for health, Labour MPs and NMPs, members who feel strongly about healthcare who will carry the torch forward. Most importantly, the MOH political office holders will continue to put forth our agenda and address the concerns of our stakeholders. We are not on different sides. We are all on the same side, trying to make the system better for Singaporeans. And for NMPs, after you step down, I hope you'll continue to advise and cheer us at the side. So let us all continue to advocate for a better healthcare system for everyone. So health is for all, and all is for health. Thank you.